Hello, and welcome to Rowan University. Please take a moment to locate the fire exit nearest your seat and aisle. In an emergency, please exit quickly and quietly. Regarding this event, please note the following. Smoking is not permitted in the auditorium or throughout the building. Please disable all cell phones, beepers, or other electronic devices. Food and beverages are not permitted. The use of cameras and recording equipment is strictly prohibited in the auditorium. Thank you for your cooperation. Enjoy the program.
Good afternoon, Provost Newell, senior leadership of Rowan University, and colleagues. Welcome, family and friends of the class of 2022. I'm Annette Raboli, and I have the honor of being the Dean of Cooper Medical School of Rowan University. What a happy occasion as we gather here in Flieger Concert Hall to welcome our newest junior colleagues into the profession of medicine. I'm going to ask the members of the class of 2022 to please stand and turn to face your family and friends. These are the people that have loved you and supported you on this magnificent journey that you are on. This event, please be seated. This event is so important to our community as we welcome you that several dignitaries from Rowan University and from our major clinical affiliate, Cooper University Healthcare, in addition to our CMSRU leadership team, are here to celebrate with us, and I'd like to recognize them. University Provost Dr. James Newell, Senior leaders of Rowan University, Ms. Amy Bozio, Ms. Melissa Leecroft, Mr. Bob Zazali. Senior leaders of Cooper University Healthcare, Dr. Anthony Mazzarelli, co-president, and Dr. Roland Schwarting, president of the medical staff. CMSRU deans, Dr. Andrea Bottaro. I'll read the names and then we have quite a few here, so I'll read the names first. Dr. Rose Kim, Dr. William Coker, Dr. Harry Mazurek, again, Dr. Anthony Mazzarelli, Dr. Jocelyn Mitchell-Williams, Dr. Susan Perlis, Dr. Erin Pukanis, Dr. Larry Weisberg. Our CMSRU chairs who are in attendance as well, Dr. Robin Perry, Dr. Roland Schwarting, Dr. Todd Siegel, Dr. Stephen Treziak. Class of 2022, today you will do two things that will mark your formal entry into the profession of medicine. First, you will be cloaked with the white coat, the symbol of the medical profession. It's a symbol that's actually relatively recent compared to the long and rich history of medicine. The wearing of the white coat started in the late 19th century. And the reason for that was at the time there was a lot of mysticism and quackery in the practice of the healing arts. And a group of students and physicians wanted to start to emphasize a scientific basis for medicine. So they decided that physicians should wear a white coat representing the laboratory and science. But the white coat is merely a symbol. It is how the person feels and wears their white coat that is most important. White coat ceremonies are even more recent. The first one occurred in 1993 and was organized by Arnold Gold at Columbia University. Now they occur worldwide. The gold pin on your coat is a gift from the Arnold Gold Foundation. Please wear it proudly. Dr. Jordan Cohen from the Arnold Gold Foundation has called humanism the passion that animates authentic professionalism. We are extremely proud to host a Gold Humanism chapter at CMSRU. Secondly, today you will recite the ancient oath of Hippocrates. This oath unites all physicians worldwide and throughout the ages in the art of healing. In taking the oath, you will commit to the very highest standards of our profession. Today, you become a medical professional. You may ask, what is a professional? A medical professional is someone who accepts the responsibilities, the obligations, and the sacrifices that go with the privilege, and indeed it is a privilege to study and practice medicine. But above all, a medical professional is someone who always places the interests of the patient above their own. Today you will also receive a special gift courtesy of the medical staff of Cooper University Healthcare, a Litton stethoscope. This will be presented to you by Dr. Roland Schwarting, President of the medical staff of Cooper. Class of 2022, you were chosen by our Faculty Admissions Committee because they felt that you have the right stuff. We're a school that is very driven by our mission to serve our community, to develop you as culturally competent physicians who will be leaders and very strong advocates for your patients. You're the future of medicine, and the future of our profession truly depends on you. Class of 2022, medicine awaits you with open arms. Each of you is a very special person with a very special role to play. Each of you will need to discover, to develop, and then use your incredible talents and skills in the service of others. Each of you will need to continue to develop the traits that are essential to the development of an excellent physician: altruism, humility, commitment, kindness, respect, and compassion. This process has already begun, for in choosing medicine, you have proclaimed your desire to serve others. Our job over the next 4 years is to help you become the person who fills your white coat with the attitudes and skills worthy of our noble profession. Please accept my best wishes to all of you. I'd like to now introduce Dr. James Newell. As we said, he's our university provost. And along with President Hushmand, who unfortunately had to send his regrets for today, Rowan has been on an amazing meteoric rise regionally and now nationally. I think it's especially pertinent, and I said this to Dr. Newell when we were waiting backstage, in the early days of the formation of our school, 2009 to 2010, Dr. Newell was instrumental on the committees that helped form the school, including the curriculum committee. So all of you owe our wonderful curriculum to some of his early work. So please join me in welcoming Dr. Newell.
So I have the privilege of welcoming you all here today, but I've learned from doing this a number of times that everyone out there has a question of what is a provost? So the provost is the senior vice president for academic affairs. Anything that happens inside a classroom or a laboratory in the university is my responsibility. Or my daughter, who's a freshman at Rowan this year, likes to tell her friends, you know, he's the vice president. Now, normally I would make a joke about whoever happened to be vice president of the United States right now, but with everything going on in Washington, you'll understand if I skip that today. This is a wonderful event, and I can feel the pride radiating from the parents and family members in the audience. And you know that this is significant because they've written the first tuition checks and they still came. This is an incredible time, and you should be so excited about the journey you are about to undertake. As I was thinking about what would be an appropriate inspirational quote to welcome you with today, I decided to fall back on, "Medical school is easy," said no one ever. The reality is you are going to find the next 4 years to be among the most challenging, frustrating, exciting, continuously reinventing your understanding of the medical profession of any 4 years you will ever experience in your life. But the reality is, it's the training that you begin in these 4 years that are going to put you in the position to literally hold the lives of people in their hands. You have chosen a very humanistic focused medical program that recognizes that it's not just the patient that you are dealing with, but it is the future of their families, of their children, of their communities. That is an enormous responsibility. And the training you are going to receive over the next 4 years is unparalleled at preparing you to manage that responsibility. I too am incredibly proud of the choice you have made, and I am thrilled to welcome you here today and look forward to watching you receive your white coats. Congratulations and welcome to Rowan University.
It's truly an honor for me to introduce Dr. Alan Tunkel. His bio is in your booklet, so I'm not going to read it. It captures his stellar professional accomplishments, but doesn't do justice to the measure of the man and the physician. He epitomizes the highest ideals of our profession. I believe that his personal experiences, including those on the other side of the stethoscope as a patient, have molded the physician he is today. I have been personally blessed to have Dr. Tunkel as my colleague and friend. Dr. Tunkel.
Dean Raboli, thanks so much for the invitation to be here today to give you some remarks at the White Coat ceremony. This was actually a pretty difficult speech for me to write because I've been a physician since before all of you were born. And I wanted to be sure that my remarks would have some impact on your roles as medical students and future physicians. I'm going to deviate a little bit from some of these talks because a lot of them, the person talks about the white coat. I'm not going to talk about the white coat at all. But I decided that I would talk to you from my perspective as a patient, view from the bed, so to speak, as I had a personal experience in dealing with a potentially fatal illness, or one that would definitely have been fatal to me without rapid and appropriate treatment. So you'll hear a lot about me, and I hope to use my illness to give you some important insights as I reflect on my experiences. So at the time, I was 62 years old, and the date, which I will never forget, was March 17th, 2017. So I remember the day very well because it was not only St. Patrick's Day, but it was Match Day, an event in which all graduating medical school seniors find out where they will be doing residency training. So you may not know a lot about it now, but you'll soon learn that this is one of the most enjoyable days that you're going to have during your medical school experience. So as you read in the bio, I'm the medical education dean at Brown, and Match Day is a huge celebration. It includes a band, the students are there, they invite their families, significant others, and as they open their envelopes, all these balloons drop from the ceiling. And as the medical education dean, I was selected as one of the people to hand the envelopes to the students to let them know where they would be spending the next 3 to 7 years. And I felt really well, really enjoyed the ceremony. About mid-afternoon, though, I noticed some muscle aches, really no other symptoms, but they kept returning despite analgesics. And that night, there was a dinner at a hotel in Providence called the Biltmore Hotel to kick off a weekend symposium that we were holding at the medical school that was called The Patient, the Practitioner, and the Computer. The theme of how the electronic health record has impacted communication between patients and physicians and might even make physicians less humanistic. This symposium was the brainchild of one of our doctors by the name of Betsy Toll. You may not know her, but some of you may be aware that Betsy wrote an opinion piece that was published in the Journal of the American Medical Association in 2012 that was entitled The Cost of Technology. So her opinion piece includes a drawing by an artist who's actually a 7-year-old girl. And it's a picture she drew of her sitting on the examining table with her sister and mother nearby. And in the drawing sits the doctor, staring at that computer with his back to the patient. So even children understand issues with the electronic health record. So as one of the people who supported the symposium, Betsy asked me to give some opening remarks, and I took the liberty of talking about a personal experience I had with the electronic health record that had occurred about 5 years earlier. At the time, I was chair of the Department of Medicine at a teaching hospital here in New Jersey, and I had just been diagnosed with diffuse large B-cell lymphoma. I was pretty sick at the time and needed to be urgently admitted to my hospital for chemotherapy. Now, you would think that this diagnosis in and of itself was an anxiety-producing event, but there was another issue, and one that gave me even greater concern, because this was the week that my hospital was rolling out their electronic health record. It was a chaotic time, everyone was being trained how to use it, and would I be able to survive? Obviously I did, or I wouldn't be in front of you. Got all the right medications, no errors in my care. So I decided to tell the audience at the conference about one particular experience regarding my hospitalization. After discharge, of course, I decided to go into the hospital record to review my chart. So on the initial history, there was a question, and the question was pregnancy. And the box that was checked was patient denies. Now, this is an issue on two levels, actually. The first is the obvious one, but the second is that no one actually asked me if I was pregnant. And this highlights a potential issue with an electronic health record, just checking the boxes. So we'll get back to that a little later. So let me go back to March 17, 2017 at the Biltmore Hotel. So about 30 minutes after my remarks during the keynote, I started to feel lightheaded, sweating, a little nauseated, felt like I was going to pass out, and I hurried out of the banquet hall into the lobby. And once I got there, I fell to the floor. And I thought I was having some kind of vasovagal response. And I think a lot of the people attending the keynote noticed something was wrong, and a lot of doctors followed me out. Chair of Family Medicine, the director of the Cancer Center, and a few others as well. And they had me lay on the ground, put my feet on a chair, and I suppose if you're going to pass out, a medical conference is probably the best place to do it. My pulse was difficult to palpate, was fast, no other symptoms, and the director of the Cancer Center convinced me that I should go to the ER. So fire rescue was called, I was loaded into the ambulance, and I was already feeling much better in the ambulance, not sure really why I needed to go to the hospital at all, but figured I'd just get checked out and then likely released. So I arrived at the ER at Rhode Island Hospital, feeling fine, still some muscle aches, no other symptoms. Really, the only medications I took were aspirin, and I had a little hypertension, so I was on an antihypertensive. I'm allergic to kiwi, but I hadn't had any since 1989, so I knew that was not the problem. No one asked me about drug use or sexual activity, probably because they were afraid of what I might say. After all, I was a teenager in the 1960s. I had received my yearly influenza vaccine the past November and also received the vaccine to prevent pneumococcal pneumonia. So my exam in the ER, my vital signs were really normal. I had no fever, maybe my heart rate was up a little bit, and my blood pressure was fine. And they checked the oxygenation in my blood was 99% on room air, all essentially normal. Lungs were clear, nothing abnormal in my physical exam, and my labs were pretty normal too. My white count was 16,200. Normal, you will learn, is maybe around 4,000 to 11,000. It was up a bit, but generally non-specific. And my chest x-ray and electrocardiogram were normal. So the ER attending, who I know very well, came to see me and, didn't seem to think there was any bacterial infection or anything else, and she was fine discharging me to home. But I told her I still didn't feel quite normal, so we talked about it a little bit, and she decided to admit me with plans to have me monitored, check my lab studies in the morning, and she gave me some intravenous fluids. And she said, I don't think we need to give you any antibiotics, and I'm an infectious disease physician. I said, that sounded fine to me. The resident was called to do my history and exam. He also did not ask me about drug use or take a sexual history. And I was left on the stretcher in the ER, hooked up to the monitor, wearing my blood pressure cuff that would intermittently inflate and deflate. The staff said the hospital was pretty full, so I might be sitting in the ER a while, waiting for a bed. And it was midnight by this time, so I just tried to fall asleep on the stretcher. About 1:30 in the morning, I awoke and I looked toward the monitor. My pulse was now 130 beats per minute, and my blood pressure was dangerously low at 75/50. Now I had a fever. I was getting short of breath. The oxygen level in my blood had decreased to 92% from a normal 99%. So called the nurse and said, could you please get the doctor? So he increased the rate of fluids and he ordered a stat CAT scan of my chest, abdomen, and pelvis, took cultures of my blood and started me on these two antibiotics, vancomycin and piperacillin tazobactam, which you will learn about, which covers just about every bacterium you could possibly think of. So the CAT scan of my chest showed that I had a right lower lobe pneumonia, but was otherwise normal. Even though my chest x-ray was normal, it showed up later. After 4 liters of fluid, my blood pressure was unchanged, still dangerously low. I then asked them to add a third antibiotic, azithromycin, which should be given for patients with pneumonia from the community, which they did. So they took the advice of the patient. So now I'm sent to the critical area of the ER, meet a new group of physicians. A resident preps me to place a central line in my right internal jugular vein in my neck and adds another drug called norepinephrine to raise my blood pressure. And then I'm sent to the ICU because I'm in septic shock. So by the time I reached the ICU at 6 o'clock in the morning, the ICU staff worked to get me situated. They drew new labs. My oxygen saturation's dropping, so they increased the oxygen. When my labs returned, I asked the nurse for the results. My white count was now low, 2,600, below normal. I remember saying that was not good. It basically means my own immune system was being overwhelmed, not doing a great job in helping me control my infection. Other lab studies were not looking good. My breathing's getting more labored, and I was placed on high-flow oxygen. I remember saying to my nurse that I thought I was likely going to be intubated and placed on a ventilator. And she then said something to me that has actually stayed with me. She said, "Alan, I've been watching people breathe for 27 years, and there are many other things we can do first." So I got placed on something called BiPAP to keep my lungs expanded, really uncomfortable, but did the trick. And by midday, I'd received a total of 9 liters of normal saline. My hands were swollen, but fortunately the norepinephrine, although it was maintaining my blood pressure, could not be stopped. The infectious diseases service was consulted, probably because I'm a dean. I must have something more exotic than a simple community-acquired pneumonia. So they didn't make any changes in my antibiotics and asked me if that was okay with me. I said that was fine. So the next day, my white count was about 8,100. Now I'm getting a lot of bands, which are immature forms, and my platelets are dropping, all indications that my infection is uncontrolled. All of my blood cultures are negative, so the exact cause of my pneumonia and sepsis was not identified. The residents were in early each day to see me. I now had decreased breath sounds and crackles at my right base on examination of my chest, clear signs of pneumonia. Now, since I'm an educator, I suggested that they should check me for something called egophony. So that's when you put your stethoscope over the chest, an area of the lung where there's a pneumonia, and you ask the patient to say E, but the sound that comes through is a loud A. So I proceeded to tell them, I'm an educator, I wanted to tell them how egophony was discovered. And I'm now going to tell you this story that maybe even some of your attendings are not going to know about. So egophony is Greek for the voice of the goat. And it's the goat-like and bleeding sound produced by the patient's voice when heard through the stethoscope over an area of consolidation. So E to A changes are a more recent variant of egophony, but I asked them how that was determined. I mean, how did anybody ever figure out when you put a stethoscope over the chest over an area of pneumonia, why do you ask the patient to say E and this A comes out? I mean, why not ask them to say A or O or U? So whenever questions of this sort come up in the history of medicine, there are 3 major requirements, and they are a British missionary, a far-flung land, and serendipity. Lots of serendipity. And in this case, there was a British missionary named Shibley who in the 1920s was practicing missionary medicine in China. And part of his job consisted of auscultating chest while patients were saying 1, 2, 3. And since the patients were Chinese, the Mandarin dialect for the number 1 was pronounced E in the province where Shibley was working at the time. So that E turned into a loud A whenever there was pneumonia. So Shibley reported this finding in the Chinese Medical Journal in 1922, the 100th anniversary when all of you will graduate from medical school. Anyway, the residents listened intently as I told them all about this. They never checked me for egophony. I don't think it had much impact on them. They were probably thinking of the other sick patients they needed to see and were ready to move on. So during my time in the ICU, people started coming to see me. The dean of the medical school, who happened to be a pulmonary critical care specialist, stopped by several times. The chair, vice chair, program director of internal medicine, head of pulmonary critical care. People from the conference stopped by, a lot of friends in the Division of Infectious Disease. I was happy they all stopped by, but it was really hard to rest. And the weekend was over, my new attending physician told me that no one except family and my care team was now going to be allowed to come by. I needed to rest. She personally called the dean, told him to stay away. A sign was placed on my door, no visitors except family. They offered to hide my identity as a patient, but I didn't think it was necessary. Sleeping at night was really difficult. The ICU bed was very uncomfortable. And I don't like to take any medications, but the resident convinced me to take some Ambien at night. And I was sleeping so badly, I asked him to give me the hallucinogenic dose. So over the next several days, I started feeling better. Team was able to get me off BiPAP, and they weaned off the norepinephrine after about 3 days. I was still short of breath. I still had crackles both way up in my lungs. And this was the fluid that I received, the benefits of being 9 liters positive. So they started me on diuretics to get the fluid off. And that worked over a couple of days. And on my 7th day in the intensive care unit, I was doing better, felt I'd likely be transferred out later that day. The residents stopped by early in the morning, confirmed my improved status, and said the team would be rounding on me later that morning. They had other patients to see first. Sounded fine to me. And a new ICU attending was covering for that day. However, the ICU attending came to see me 15 minutes later. And he said he'd be formally rounding on me later, but wondered if he could ask me a question. And he said, "Alan, I have a patient in the next bed." I'm not going to finish the sentence, actually, and I won't get into more details, but perhaps his note on the patient later that day reflected the input from the patient in bed 18. So after 1 week in the ICU, I was transferred to the general medicine unit to complete my antibiotics. Now a new resident saw me, did her own history. She actually asked me about drug use and sexual activity, but she had been one of our Brown medical students, and she knows I would not have liked it if she were not complete. Over the next few days, I began ambulating more, was able to have a good oxygen saturation of 95% without oxygen, and this was my cue to get out of the hospital. Hospitals are dangerous places. Infectious diseases had signed off days ago, one day after my antibiotics were changed to oral administration. I actually told them they could stop coming by because I could handle it from here. Pulmonary was still stopping by. On the day of my discharge, they offered to follow me as an outpatient, but as they noted in that note that day, I politely declined. The etiology of my pneumonia and sepsis were actually never determined, but I'm sure I had pneumococcal pneumonia and sepsis. You'll find out, this was a classic presentation. So now let me give you my few reflections and messages, 5 to be exact. First is that the hospital chart is not always accurate. Of course I looked at my chart again. Seemed to be a few inaccurate dates that got carried over, like that I had lymphoma in 2002 instead of 2012, that I was on hydrocodone, acetaminophen as a current medication. I think that was prescribed to me after an ER visit a couple of years earlier for some knee tendonitis, although I never even had the prescription filled. And there seemed to be some copying and pasting, even in later notes from a week after my admission, and some notes indicating that some completed studies were still pending. Or the note from the dietitian that I had a cholecystectomy in 1999. So as far as I know, I still have my gallbladder. I did though have a vasectomy in 1999. Well, I guess they're both ectomies, so it's close enough. On a positive note, in almost every description of me, I was described as a pleasant 62-year-old gentleman. Made me happy. I think that was accurate. So the message to you is to be accurate and complete in the health record. Rely on the information that you gather personally from the patient. Second, and with all due respect to everyone else, and of course acknowledging that the approach to a patient's care is a team effort, the nurses are the most important people in the hospital. They spent the most time with me, gave me great care, especially in the intensive care unit. The nurses are the heart and soul of any hospital. In addition to spending the most time with me, they ensured that through this difficult experience, I was able to maintain my dignity when everything about being in the hospital involves others taking care of your every need and a loss of dignity. So you'll learn much from the nurses, as well as all the other members of the healthcare team. Don't forget to ask them what they think and benefit from their knowledge and expertise. The third is that recovery from a serious illness takes a long time. So a very close friend of mine is head of critical care at the National Institutes of Health in Bethesda, and he sent me a note during my hospitalization and made several important points. The first was that physical rehabilitation is a lot harder than it appears in terms of returning to the original state of activity. He suggested a physical therapist taking a professional approach to regaining strength and endurance. And to be honest, I didn't think it would take months to feel better, but he was right. I should have known this because even for minor activities in the ICU, I needed assistance. I needed help just sitting up in bed so folks could listen to my chest. I needed 2 people to pull me up in bed. For weeks, almost doing all activities was strained and quite stressful. And actually, when I got home, I wanted to go out and I went food shopping with my daughter. My shoelace was untied. I needed her to tie it for me. However, I decided not to get professional rehab, even though it was offered. The second point was that cognitive abilities take weeks or months to recover. And I didn't really believe that either, because I was awake and alert throughout my hospitalization, although most certainly had periods of low blood pressure and low oxygenation. I would have to say that I was not back to normal cognitively for about 3 to 4 months. Fortunately, because I'm a dean, I have a job that does not require intact cognition. Perhaps I was even better at my job. Of course, I decided not to do any patient care until I was ready and wound up not doing my inpatient service that was scheduled for June. Fourth, I want to talk about impact on others. And this was my major concern during my hospitalization, probably relates to my wife, who has some serious illnesses. And about 15 years earlier, she was diagnosed with a disease called idiopathic cerebellar degeneration. You'll learn about that disease sometime in medical school. And it progressed over the years to the point she was wheelchair dependent. And on top of that, she's had multiple strokes over the prior 3 years, which have even made the situation worse. In fact, 1 month before my illness, she had spent 9 weeks in the hospital and then rehab for her 4th stroke and a complication of blood clots in both of her legs. And I'm her primary caregiver, and I spent my first day in the ICU arranging for extended home care for her. And of course, my children were a great help, but it helped me to understand how hospitalizations can disrupt people's lives to a greater extent than I had previously imagined. And actually, my wife, not my health, was a major concern, and I was worried about what would happen to her if I did not survive. And it really put things into an important perspective for me, and fortunately, many of my friends stopped by our home to be sure she was okay. And finally, were there any positive aspects to all of this? One was that I was overweight, wound up losing about 15 pounds. As you can tell, I have a little ways to go. Because it was embarrassing to look at my chart and see that my body mass index, which is a measure of body fat based on height and weight, was elevated. And they had it in red numbers followed by an exclamation point. So the result of the weight loss is that I'm no longer hypertensive, and actually now aspirin's my only medication, even more than a year after the event. Even my lipid panel was not looking that good, and it has since normalized. So I now have the cure for these conditions. I'll put you all into septic shock. And the other positive aspect relates to my family. And as you can imagine, these 2 illnesses have had a significant impact on them, but also in positive ways. Our family has always been very close. But in many ways, my illnesses have enhanced our relationships. And enriched our lives. So I'm truly fortunate in this regard. We can't always say the same for many others, whose lives have been devastated and do not have the emotional support they need in order to recover. And unfortunately, you're going to see many patients throughout your careers who do not have this support. And you need to expend the effort to help them through these life-altering events. Well, that's all I have to say, and I hope these reflections have been useful. Thanks, and best of luck to everyone.
Many thanks to Dr. Tunkel for sharing a truly inspirational and human, personal story. It's truly appreciated. Thank you so much. Turn it over to Dr.
Good afternoon. My name is Dr. Erin Buchanan, and I'm the Assistant Dean for Student Affairs. It is an honor to share in this day with all of you. In a few minutes, each student will be cloaked in their white coat by directors from the students' respective advisory college learning community. The advisory colleges are a center of support, career mentorship and professional development for the students during their 4 years of medical school. Each college is named for a significant historical figure in medicine and is directed by CMSRU faculty physicians who play an integral role in the student's journey. The 4 colleges and directors are Benjamin Rush College, directed by Drs. Tony Spevitz, Emily Scattergood, Greg Kubicek, and Leo Iliadis. William Osler College, directed by Drs. Richard Fisher, Emily Damuth, Stephanie Wilsey-Smith, and Dory Susan Barrington. Henry Cushing College, directed by Drs. Lisa Reed, Sam Bader, Joanne Mazzarelli, and Ashley Decker. Elizabeth Blackwell College, directed by Drs. Ramya Latano, Anat Feingold, Don Solomon, and Chris Deitch. The colleges are led by Dr. Emily Scattergood, the Senior Director of the Advisory College System. As we call the students to the stage, audience, we ask that you please hold your applause until after all of the students have received their white coats. Would the students of Rush College please rise? Leslie Abraham. Jamila Abramova. Nader Azim. Benjamin Borowski. Joey Bukaram. Nicholas Cho. Caroline Correa. Megan Dunleavy. Yusuf Al-Fadatri. Lindsay Fleischer. Michael Glass. Akil Gola. Helen Kim. Kimberly Coleman. Michael Lai. Lindsay Lee. Natasha Mather. Sean McHugh. Rebecca Neal, Parth Patel, Sean Kyungman Rowe, Brian Schoenwald, Anna Torciano, Victoria Wang, Elena Webb, Samantha Weiss, Wesley Yuen, Would the students of Osler College please rise? Shirag Arya, Bridget Bolsham, Rishi Chauhan, Ashley Creighton, Connor William Crudelli, Klaus D'Angeli, Edward Dulesky, Manas Dayalankar, Cindy Duke, Chenwei Gao, Margaret Heller, Samuel Hoffbauer, Prasigna Koda, Andrew Lazo, Atika Memon, Andrew Needleman, Tatiana Nguyen. Vidish Hindiya. Raj Patel. Savan Patel. Riya Raju. Aditi Ranade. Michael Rosenheck. Jackson Sademi. Sydney Topfer. Inga Wong. Marissa Wozniak. Would the students of Cushing College please rise? Augusto L. Wang. Rita Oro. Shalway Monica Banks. Lauren Beck. Matthew Bai. Austin Chen. Daniel DiPolo. Neil Desai. Timothy Fisher. Ariane Foster. Matthew Goldner. Roberto Gonzalez Marino. Jillian Hall. Christopher Johnson. Azmir Kamasani. Simran Kripalani. Shristi Kolshrest. Alvin Mercado. Liam Martin Ortales O'Neill. Mansoor Muhammad. Maya Patel. Anjali Savendra. Justin Tiang Sun. Adam Ungamak. Michelle Ann Wong. Charles Walkenek. Mark Yorker. It's tougher than it looks. Would the students of Blackwell College please rise? Nicholas Basco. Meghna Bhattacharya. Alexander Bjorling. Nicholas Dereshevsky. Kiana De Guzman. Rahul Kumar. Colleen Iwala. Justin Matthew. Katrina Manta. Andrew Myers. Zachary Nelson. Shrina Patel. Elena Perlow. Donna Perusa. Christian Pilot. Daniel Pineda. Maher Karashi. Ashley Ray. Savina Reed. Jacob Reardon. Javier Rivera. Alexandra Seabury. Shivani Talwar. Thomas Tessachor. Aditi Trivedi. Ryan White. And last but not least, Walter Whistler.
and I forgot to mention it to you. If there's somebody in the audience becomes a pathologist, you have to return the stethoscope.
So you may or may not know that Dr. Schwarting is a pathologist and a very good friend of Dr. Coker's. Now, I think next we'll have the recitation of the Hippocratic Oath. I think it's especially pertinent that this is being delivered by Dr. Coker, since you are the first class that he has recruited as Associate Dean of Admissions. So please make him proud.
Good afternoon, everyone, and my special welcome and congratulations to the class of 2022. As Dr. Riboli just mentioned, most of you know that about a year and a half ago I transitioned from my role in curriculum within the school to admissions, and I can't begin to tell you how proud I am of all of you. Also to reflect on Dr. Newell's words earlier, and thank you for coming to CMSRU, choosing us to provide your medical education. You've also allowed me to have another year of job security here, so thank you for that. I have to tell you, as I look out at you, I love what I'm seeing. This is terrific. Again, congratulations. I'd like to ask the members of the class of 2022 to stand at this point. I'd also like to invite any physicians, any of my colleagues on the stage, and any physicians who are in the audience to also stand and renew your oath along with the class of 2022. I would ask you that you read along with me and recite the oath as we go. I do solemnly swear by that which I hold most sacred, that I will be loyal to the profession of medicine and just and generous to its members, that I will lead my life and practice my art in uprightness and honor, that into whatsoever house I shall enter, it shall be for the good of the sick to the utmost of my power, holding myself aloof from wrong, from corruption, from the tempting of others to vice, that I will exercise my art solely for the cure of my patients and will give no drug, perform no operation for a criminal purpose, even if solicited, far less suggested. That whatsoever I shall see or hear of the lives of my patients, which is not fit to be spoken, I will keep inviolably secret. These things I do promise, and in proportion as I am faithful to this oath, may happiness and good repute be ever mine, the opposite if I shall be forsworn. Congratulations once again.
Students, now that you have your white coats, you may notice that when you reach into your coat pockets, you will find notes. These notes were written by your family, friends, faculty, fellow students, and loved ones in an expression of support and encouragement on this very special day in your medical education. Save these notes, cherish these notes, so that you may look back on this day in the future and recognize how much you have grown.
In closing the ceremony, I'd like to once again thank Dr. Alan Tunkel for his inspirational words. Thank Dr. Jim Newell for his words as well, and thank Dr. Schwarting as medical staff president for supplying the stethoscopes. I'd also like to thank some of the folks who do the real work for today's event, from the Office of Student Affairs, Dr. Pukanis, Janine Thomas, Dr. Lombardi, and events, Gail Uhuru Stevens and Sharon Clark as well. So I'd like to thank those individuals. Please give them a round of applause for this event. I joined Dr. Coker in wishing all of you congratulations, class of 2022, and I do love what I see as well. I think it's a great class, and I look forward to a great 4 years with you. We are having a reception. We've moved it indoors because of concerns with the weather. I'd like the class to stay behind, and I'd like our deans, Dr. Newell, Dr. Tunkel, Dr. Schwarting, to please join us for some photos. But family and friends, please do go and start enjoying the reception. Thank you for your attendance.
Very personal, very nice.